See the next talk. There we go. My name is Spero Cataland. I'm a hematologist at the Ohio State University in Columbus, Ohio. And what I'm going to talk about is really going to, I think, bring together a lot of the issues that we've already had questions about and discussed. It's the treatment landscape for acquired or immune-mediated TTP. And just to get this straight, because there's some confusion between regulatory approval and the name that investigators will refer to TTP. The correct term that we use is immune-mediated TTP to imply it's an immune system that's causing the problem. This is an autoimmune disease. The term acquired, though, for some is more descriptive, and I think it's just as equally accurate as well. So the first we're going to talk about is treatment of immune-mediated TTP or iTTP. So we've talked about this ADAMTS13 protease and TTP and its role in the pathophysiology of the disease. So if you see this figure here from the late Evan Sadler, I think it describes, I think, quite well what happens and as simply as it can be done. This here is the von Willebrand factor protein. It's produced and secreted from these endothelial cells that line the smallest blood vessels. So what is supposed to happen is as it is secreted, you have this ADAMTS13 protease normally, which cleaves or cuts this down to the normal size pieces. And this happens in the smallest vessels, what we say is higher shear forces, where the blood is rushing through. When you get these normal sized pieces, you get clotting where it is supposed to occur, in a cut in your vessel, an injury, a wound, a trauma, something like that. In the pathological case of when you don't have this ADAMTS13 deficiency, and when you're born without it, we call it congenital TTP, and when you acquire this, an antibody causes the problem. An antibody clears this. We call it immune-mediated or acquired TTP. This cutting doesn't happen, and these large pieces then circulate. And these large pieces are more likely and more avidly will bind platelets and form clots. So they form clots not only where they're supposed to, but where they're not supposed to. And that becomes the disease, a widespread microthrombotic or small vessel clotting disease. This is still a clinical diagnosis, meaning you still diagnose this with finding a low platelet count, these fragmented cells in the peripheral blood that you heard, and the lack of another explanation for this. But this ADAMTS13 test serves to confirm the diagnosis. So in the right clinical scenario, this test being low, and especially less than 20%, confirms the diagnosis, confirms this clinical diagnosis. This also implies a specific treatment course that we're going to talk about. It's not just replacing the ADAMTS13, it's actually having to remove an antibody. And we've talked a lot about plasma exchange therapy. You'll hear it referred to as apheresis. But really what it's trying to do is help to induce a response or put the disease into remission so it's no longer active. And what happens is the blood goes into this machine, which is the centrifugation. It spins and it separates the different components of your blood by their density. So red cells will fall to the bottom. There's a level of platelets and the plasma. And these machines can be used to remove whatever you want to remove. In the case of TTP, we're removing the plasma, which is the liquid part of the blood without the cells. So this is where these antibodies are. So when we're removing this plasma and the antibodies, and what goes back into the patient then is the normal plasma, donor plasma, that does not have these antibodies, presumably, and has this ADAMTS13. As life-saving as this is, and as much as we know about this, it's still really not clear to this day what is actually more important, the removing of an antibody or the infusing of ADAMTS13, which can sometimes bind up these antibodies. And we'll come back to this at the end of the talk. So the idea is a normal platelet count and a normal LDH, which signifies the disease has sort of cooled off. And we talk about a response of the disease. So if things are normal, then we stop the plasma exchange and watch for what's called exacerbations of TTP. So this is an early recurrence of TTP or the need to restart plasma exchange within 30 days of the last plasma exchange procedure. It's defined this way to signify what is not a new relapse, if you will, but it's a continuation of the previous episode. It happens in about a third of cases, and it's certainly problematic. It leads to the restarting of plasma exchange therapy, likely back to the full dose of steroids, and likely additional doses of immune suppressive therapy. That's an important clinical trial endpoint that we'll talk about when we talk about caplacizumab. So what we're trying to do with plasma exchange is remove these antibodies. What about immune suppressive therapy that we talk about? We talk about steroids, we talk about rituximab. So while we're removing the antibodies, you want to do things to decrease the production of these antibodies as well. And this slide shows some data from a clinical trial, and the details aren't important. It was looking at the difference. So everybody in this study got plasma exchange who had TTP, and half got prednisone, which is shown in blue in both of these, and half got cyclosporin. The idea is which one of these does a better job at suppressing the antibodies. The short story is the prednisone arm won, but look at the details, which I think is more important. Again, these steroids are supposed to suppress the production of these antibodies. So you're removing it, you're also stopping or decreasing the production of them. And what we measure in patients, and down below here is this ADAMTS13 activity that we talked about. So pre-treatment, before any therapy at all of the patients were undetectable, less than 10%. Then what we measured in this particular study is the ADAMTS13 activity and the antibodies that are causing this deficiency, that are causing it to be low in the first 4 weeks after you stop plasma exchange. You might ask why you don't measure it during plasma exchange, and it can be done. There's been some studies on that, but it's very difficult to make sense of the information because of the constant effects of the plasma exchange. So we like to know what's happening to the ADAMTS13 and the antibodies more accurate and consistent after the plasma exchange is stopped. So week 1 is at least 5 days after the last plasma exchange. So what you see here is not going to be related to the plasma you infused. But if you look in blue, what happens? Look at the top for the antibodies from the very beginning of the diagnosis to when they're out of the hospital that first week. The antibodies are much lower. But yet at week 1, you still have ADAMTS13 activity on average that has not completely recovered. And it might make sense if I tell you that the greatest risk for this exacerbation is actually in the first 2 weeks of this 30 days. You can see exactly why. So with plasma exchange, with steroids, you still don't see an appreciable increase in the majority of patients till after 2 weeks. So that kind of gives you an idea of what we're doing, removing the antibodies, trying to decrease the production of these antibodies to keep them in a remission that sustains and that can be sustained and last a long time. Many of you have taken steroids, so you know what I'm talking about. Steroids can be very effective in TTP. They can be very damaging in terms of side effects, mood issues, irritability, weight gain, water retention, infections, long-term osteoporosis, things that can affect the joints called avascular necrosis. A very good short-term treatment, but really should not be given long-term for these reasons. We're going to talk more about rituximab today, I'm certain, and with Marie Scully, I know we will. And these are actually data from some of the research that she did where they gave rituximab as early as possible in the first 3 days after they started the treatment for TTP, the plasma exchange therapy. And simply put, this is an antibody that binds to a marker called CD20, which is found on B cells. It's these B cells that make the antibodies. So very much like steroids, we're targeting and clearing these B cells that make the antibodies to try to get a more sustained remission that lasts longer. And this is known to last longer than the effect of steroids. But studies also been done to look at rituximab. Is it better if you give it in the first 3 days, or can you wait a week to get it? And the final answer is most likely it doesn't really help in the short term. There have been some short-term measurements in terms of time to remission, but there's been no clear difference. And I think, again, if you look at the time course and the improvement in the ADAMTS13 and the suppression of the antibodies, so these are patients getting steroids, plasma exchange, and the rituximab is added on to them. But similar to the steroid story, you really don't see an improvement or start to see a significant improvement in all patients till you get out past 3 or 4 weeks. Now, what you see long-term is a significant benefit. The antibodies are suppressed, the activity is normal. In this study, out to 12 months. We now know it probably works 18 to 24 months in terms of the benefit for patients, but there's a lot of variability in that as well. So the main thing we're going to talk about, you should remember with rituximab, it has a long-term benefit. It's going to benefit you months down the road, not necessarily right up front at the time of your treatment. So how do treatment strategies differ for the initial therapy versus prevention of relapses? And because of the effectiveness of rituximab, that was first studied in patients with refractory or refractory TTP that won't go into remission with plasma exchange and steroids. It was found to be helpful in that situation, and eventually more studies were done to show that it can be effectively used to prevent relapses of TTP. But it's also important to talk about what is the risk of relapse if you had a prior diagnosis of TTP. And early attempts were trying to correlate your first presentation of the first patient episode with the risk of relapse. And your risk of relapse over time is probably not constant. It's going to fluctuate over time. When ADAMTS13 activity is measured in remission, it's known to fluctuate above and below this 20 or 10% threshold, whichever one you want to use. And I think we mentioned earlier about the risk of relapse in the ADAMTS13. So if you get low or undetectable ADAMTS13 activity, you don't automatically and uniformly relapse. And some of these data I'll show you will help explain that to you. We think you need this second hit to happen, meaning something clinically that triggers you when you're already low with your ADAMTS13 activity. So some of the first work was done by Flora Pavandi, and they looked at patients in remission, again, 30 days after the last plasma exchange, when they were in remission. And this was not necessarily serial samples. Majority of these patients had one sample. But what she found was when the ADAMTS13 activity was low, you had about 3 times the risk of relapse. If it was lower than 10% and you could find an antibody in their blood, it goes up to about 3.5 times risk for relapse in remission. So we studied the same issue really at about the same time, but in a slightly different way. So we at the time, and still do, see our patients every 3 to 6 months. So the study that we developed and looked at retrospectively, meaning these patients were already followed, and we looked back at all the previous ADAMTS13 and relapse data. So this was looking back at all of our data. And this is measuring the ADAMTS13 activity and predicting the risk of relapse in the 3 months that follow until they get it checked again. Then you measure it again and the clock starts again. And if you look at the top panel here, what you see is the lower the ADAMTS13 activity. So as you go to the left, the greater the probability of relapse. But if you look, the risk is only 0.1 or 10% over the next 10 months, which doesn't seem so great. If you look at the panel below, you take the same data and you break it down by age, 20s, 30s, 40s, up to the 60s, you start to see that the younger you get, the greater the risk of relapse. And in the youngest cohort of patients, being the 20 to 30, you start to see a risk that approaches 40 to 50% over the next 3 months. So the risk of relapse is not only the ADAMTS13. We also clearly know the younger you are, there's a greater risk. And there are other additional factors that are being studied presently by our group and others, trying to put together a model to better predict the risk of relapse. It would make sense that if you can predict relapse better, you know who exactly should get a treatment that's known to be effective. So rituximab, we already talked about. And these are data where patients in remission, and this is from Justin and all, this is the French TMA or French TTP group led by Paul Capo, who's done a lot of excellent work with rituximab. And these are data looking at relapse-free survival, if you look at this panel on the left. So people who are relapsing are dropping down lower. The red line here are the ones that received rituximab in remission. And they were treated if they had low ADAMTS13 activity. And if they were low, and usually it was double checked, they were treated to prevent relapse, not at the time of relapse. And if you just look at the difference, there are certainly less relapses in the patients that were preemptively treated with rituximab compared to the ones that were not. Now, this was compared to historical controls, meaning the study was following patients who were getting the rituximab, and we look back in the past. They look back in the past at the relapse rates, which is, in a rare disease, an acceptable way to do it. It's not the best way, which would be to follow everybody going forward. So we say these are not randomized data where one person got rituximab and one didn't. It's not clear if this is an effect on survival. We don't believe this quote unquote cures TTP, but it bumps or delays potential relapses. But you can see if we'd like to refine better who exactly needs this, we save people the time, trouble, expense, and serial monitoring that is required with this. Now, the serial monitoring of the ADAMTS13 activity is always going to be important, we believe, to help predict this risk of relapse in remission, as well as maybe some other long-term complications that we'll talk about later. But this is an emerging strategy that's really hit, I think, most treating physicians, the idea of preemptive rituximab to prevent relapses of TTP. So you've heard some talk about caplacizumab or Cablevy, and we'll talk just a little bit about this to talk about all the different components of the treatment, then at the end, pull them together with some questions that you might have. So this caplacizumab is a small molecule or a nanobody that's targeted to a specific protein or marker on a cell or a cell product. In this case, caplacizumab or Cablevy binds to what's called the A1 domain of those long VWF pieces. So when it binds to that, it prevents platelets from binding to it. It prevents the decrease in the platelet count, and it prevents the microvascular or the small vessel clotting that occurs. So it has to be remembered that caplacizumab does not change the disease. It's a temporizing measure, if you will. It blocks the downstream effects of the disease, the clotting and the low platelet count, but you still need to correct the low ADAMTS13 activity levels by getting rid of these antibodies. One of the primary endpoints was the recovery of the platelet count to normal. And you can see it happened quicker in the caplacizumab treated patients compared to the ones that got placebo. So this study, in contrast to the one I just showed you, is a prospective study, which means you were enrolled, there was a coin toss, and you got caplacizumab or you did not. And the treating physicians did not know who got which drug. The patients did not know who got which drug. So as you might expect, the patients who got caplacizumab had a shorter time to a normal platelet count, 3 versus 4.9 days. But what's very interesting, and I think even more important, is what number of patients had this early recurrence in the first 30 days, this exacerbation that we've talked about. And 3 out of 36, or 8% on the caplacizumab arm, had this early recurrence, compared to 11 out of 39, or 28%. So this 28% you should recognize as really the natural history, what we think the exacerbation risk is in all patients. So with caplacizumab, it is essentially temporizing and blocking the development of exacerbations. Now, on this study, after the caplacizumab was stopped, in the first month, 8 additional patients suffered a recurrence, or what would be called a relapse of TTP. Now, this raised attention to people that clearly this drug does not affect the underlying pathophysiology of the disease. So if you stop the drug and they're still at risk for relapse because the ADAMTS13 activity has not recovered, you could still be at risk for an early recurrence. On this slide, you can see exactly that. On this panel on the left, so this is the caplacizumab treated, this is the placebo patients. If you look at the patients that had, and follow the second column, who had an exacerbation, an early recurrence, and you can take their thing over to their square over to the side and see what their ADAMTS13 activity was at the time of the exacerbation. So there were only 3 exacerbations in the caplacizumab, and 2 of the 3 had very low ADAMTS13 activity. But if you look at the placebo arm, you can see the 9 of the 9 patients who had an exacerbation where we had samples to measure at the time of their exacerbation, all but one had undetectable ADAMTS13 activity. And this informed the future study, again, then the FDA approval and our present practice of usually continuing the caplacizumab until recovery of the ADAMTS13 activity to prevent relapses or early recurrences, exacerbations of TTP. So we're going to switch gears just a little bit and talk about supportive care strategies and what should be done in TTP patients. And make a long story short, it's really good medical care that we do for any other patient, but with some important caveats. And these are data from the Oklahoma group. And what they looked at, and these lines get kind of jumped together because this is looking at both Oklahoma and US norms. So on this axis here, you see the probability of death. So the higher the number goes, the line goes, the greater the risk of dying. And what was found by the Oklahoma investigators is over time, there was a greater risk of dying if you had a prior history of TTP compared to if you did not. So it identified that there was an increased mortality in patients with just a prior history of TTP. If you look at the details of the study, you might think this is all TTP relapses, and there are certainly those that occur, and TTP relapse that accounts for some of this, but not all of this. And there have been studies in the past now mounting data that I think are very convincing that long-term patients with a history of TTP can have some neurocognitive deficits, so short-term memory problems, functionally things like forgetting what someone just told you 30 seconds ago, not remembering where you just put your keys down. Very subtle, but very still frustrating to patients. Headaches can be an issue in patients long-term. It's documented that patients can have an increased risk for mood disorders and anxiety, which can be difficult, as well as cardiovascular disease, meaning heart disease, heart attacks, and strokes. So why this is happening is not very clear. It seems logical that the person who had more episodes would be more at risk for these episodes, but that doesn't appear to be the case. So much of the work going on now is trying to define how common these events are. Some don't experience these at all. Some have very severe long-term complications. So trying to understand how common they are right now is a very important research question. And trying to understand why they occur is also an important research question. And these are data from my colleague at Ohio State, Senthil Sukumar, who worked with Shruti Chaturvedi, one of our USTMA investigators. And what they did is a similar analysis of long-term survival, found similar things to the Oklahoma group, very similar, and showed the similar cardiovascular deaths. What was also looked at in this very small study was suggestive data that the patients in red who had on average less than 70% ADAMTS13 activity. Now, this was an average. You have to be careful. This may be something that changes over time. But to keep things consistent, this was checked in remission. An average was used. But it was thought, at least by this small study, that the lower the ADAMTS13 activity below 70%, it might start to impact the development of some of these complications. This is certainly very premature and a lot of work needs to be done. This is certainly not final, but one angle among many that we're looking at to see why these complications why they occur. If you know why they occur, then you can be in a better position to try to prevent them from occurring, which is really one of the main areas of study in the field right now. So you've heard some of these already. What are the treatments that are presently under investigation for the treatment of immune-mediated TTP? So one can ask the question, and many investigators in the field have, is there a difference between plasma exchange and caplacizumab? So you can see here, it binds to the A1 domain, preventing it from interacting with platelets. So if you will, both of these could be considered to have a similar function, meaning they're temporizing. You're getting rid of antibodies in the case of plasma exchange and adding back plasma. And in this, it's not fixing the ADAMTS13 activity either, but it's preventing the downstream clotting that can occur as a result of that. And these sort of ideas have led to some initial case reports where patients in early relapse have been treated with just caplacizumab alone, and a small series from Germany where patients weren't necessarily early in the recurrence of their disease, but were treated with caplacizumab alone. So giving them caplacizumab with steroids and rituximab. Now this is far from a standard approach. This is something that's likely going to be studied in a clinical trial. So it's not something that can be recommended now, but it's certainly where the field is at least looking at the present time. Another interesting therapeutic being studied. We've heard about immune congenital TTP and this recombinant ADAMTS13 activity. And these, in this panel on the left, you can see in congenital TTP patients in the first study, the one that's already been completed, who just got one dose and the activity was followed. You can certainly see the hours where the ADAMTS13 activity is initially higher than drops off over time. And certainly that study is ongoing presently as a very promising treatment approach of congenital TTP. But work in the lab that was done by the same company, now known as Takeda, looked at plasma samples from patients who had antibodies and saw in the lab, could you add this same recombinant ADAMTS13 to correct this ADAMTS13 activity? And indeed, that's what you saw. It's a bit complicated, but the varying dotted and solid lines reflect the higher what's called Bethesda units. So the higher the number, the higher the strength, if you will, of the inhibitor. And what you see is the stronger the inhibitor, you might require more of the recombinant ADAMTS13 activity, which makes sense. But certainly suggestive data that said you could treat potentially patients with immune-mediated TTP with this recombinant ADAMTS13. And again, the interesting question is, would you be binding up the antibody that your body would subsequently clear, or would you be restoring their ADAMTS13 function by giving them the recombinant ADAMTS13? And this is presently in clinical studies right now in an ongoing clinical trial where we hope to get those answers of how effective it is, but also potentially why is it being effective, so we can learn more, and again, apply it to other aspects of the disease potentially. Well, thank you all for your attention. I will stop now and be joined by some panelists to answer some questions. Should I stop the share, Claire?
Yeah, you can stop share. How come it's working? Is it working?
Yeah, it's working. All good?
Well, yeah, I just gotta zoom it out. Yeah. So I don't.
Let me know when you're good.
Should we put these down? Should I be muted here so we use this microphone?
All right, thank you. We got our panelists set up here. If again,
Sorry, technical problems.
thank you everybody. Thank you our panelists for joining. I just want to go ahead and have you guys introduce yourself, and then we'll go and get right to the questions.
Hello, I'm Dr. Macias, and I'm a hematologist at Baptist Health in Miami, Florida.
I'm Mo Kawandana, hematologist from University of Oklahoma.
All right. So there's one of the first questions we have is, can recombinant ADAMTS13 be designed so that antibodies won't attack it, so that it won't be cleared?
That's an excellent question. There have been researchers who have developed ADAMTS13 proteins that lack the targets. So a lot of the research, it's a bit complicated, but what are called targets or epitopes on the ADAMTS13. People have looked at which segments of it are really important for its functional activity, which ones are not, and which ones the antibodies bind to. So there have been investigators and colleagues of ours that have developed proteins that lack the target of the antibody. Part of the difficulty is there's a lot of different antibodies and different targets, and knowing exactly which one is the problem is difficult. Also, knowing what we're doing with the recombinant ADAMTS13 is important. Are we just adding back the functional protease while we give them steroids, or are we actually trying to bind up and clear the antibodies? So I think the results from this ongoing clinical trial will tell us more. If we can learn what we're really doing with the recombinant, again, are we adding back the ADAMTS13 more so than anything else, or are we binding the antibodies and getting rid of them? Is that more important? Once we know that question, then these approaches might make some more sense.
Yeah, I think very important question, and I think until we have the results of the ongoing studies, we're not able to.
As effective as plasma exchange is, no one can give you the accurate answer of how it really works. What are we actually doing? Removing something or putting something back in?
Is a patient in Canada able to get Caplevi and have it be reimbursed?
I am not sure.
We don't want someone not to be able to go back to Canada
Yeah.
to visit. No, it's not. Every healthcare system is a bit different in how they utilize an approved drug. In the US, a drug is approved based on its safety and efficacy. And if you will, the market determines how it's going to be utilized, meaning insurance providers, Medicare will decide. Other countries, including Canada, have more of a, there can be an approval process, but then also an approval for its use, meaning, is it going to be used for patients? Is it going to be used for all patients? And if something's going to go into the budget that might be expensive, like caplacizumab, is something going to have to go out? And let's not pick on Canada. Every country has their own different mechanisms of handling this. So it can be on a country to country basis. So I don't believe there's ready access to caplacizumab, meaning through commercial sources in Canada, although sometimes patients can still get access, I believe. It's not real clear though. Hope I can still go back to Canada after I said that.
Once a patient is in remission, is a relapse inevitable, or are there some patients who never relapse?
There are patients that never relapse. Typically, we say that about 30 to 40% of patients will experience a relapse. These are most common in the first year after their initial diagnosis, but it can occur at any point in their lives. And we don't know why some patients just have one episode and then never hear of the disease again, and others have multiple relapses. And certainly a risk factor for relapse is the ADAMTS13 activity that continues to be deficient, even when the patient is asymptomatic and other labs look well. But it's not the only factor to consider. And that's a lot of our research, and a lot of what we'll talk in the next discussion is how we're trying to figure out which of our patients are more prone to have relapses and how can we prevent it.
All right. Are there any clinical trials in the use of immunosuppression such as mycophenolate to prevent relapse from iTTP? Sorry, iTTP.
Yes, sir. There have been multiple studies in the past using multiple different immune suppressive therapies. But as much as we know, but most of the work has been done with rituximab. but there really have not been large-scale randomized studies. Most of the studies were called single-arm studies where everybody gets the rituximab. There are smaller studies looking at things like mycophenolate, cyclosporin, bortezomib, but they are smaller studies and hard to make any concrete conclusions. But those studies do inform your ability to suppress these antibodies. So in our treatment now of someone who's more resistant or refractory, they could be on caplacizumab in theory, which might protect them from recurring while you use immune suppressive therapies. But it's certainly an important question to know how far we need to go to treat somebody who has undetectable activity in remission. So as we said earlier, not everybody is going to relapse when they're less than 20%. The risk is higher. So you have to start balancing the risk of multiple immune suppressive therapies, which can do some damage, versus the risk of relapse, which I think, like Camilla said, is why we're trying to understand who's at greatest risk of relapse. If we know who's at greater risk, then you might do more immune suppressive therapies. So I think there have been, and there will continue to be, smaller studies that help to look at individual agents. How they fit might take a larger study to know better.
Yeah, I think that certainly, even between hematologists, we can all agree that rituximab would be our go-to for in the situation that we would like to prevent relapses, but not all the patients respond to it. And after that, some of us prefer cyclosporin, others have used mycophenolate successfully. But per se, a randomized clinical trial, I don't think we have right now.
How is the recombinant ADAMTS13 administered, and when do you think it will be completed for either acquired or congenital TTP patients?
It's given intravenously as an infusion, just like the plasma is. In terms of, it's hard to know when the studies will be completed. There's certainly time after the last dose where follow-up has to occur and the data analyzed, and then the FDA will determine in the US or the EMA in Europe if they're going to grant it regulatory approval. I don't think it's anything you're going to see in the next year. You won't see in the next year, I don't believe.
Okay. Has there ever been a study that looked at the B cell formation of the antibody to try and find a way to just prevent the antibody that clears the ADAMTS13?
You mean clears the specific?
Yeah, so to prevent whatever is getting rid of the ADAMTS13.
Prevent the formation of antibodies. I mean,
Yeah.
Certainly, the therapies that Dr. Cataland has discussed in terms of immunosuppression is aimed at stopping the production of autoantibodies against ADAMTS13 activity. But we don't know that question.
I guess the better question is who's going to develop
Right.
ADAMTS13 deficiency? And the answer is we just don't know. It's an autoimmune disease. So, and people who are more prone to autoimmune diseases can be more prone to this, but it's still very rare. What we don't know is how many people right now are running around with undetectable ADAMTS13 activity, but yet not getting in trouble. And they are certainly around, we know that, but there's no reason to measure it. And there have been no large scale studies to measure that in people. There have to be a lot more people with the deficiency. So why they develop that antibody, it's hard to see. If you flip it and look at what Bernhard Lemley did, looking at some memory B cells in Johanna Kramer, looking at memory B cells in spleens that were removed, there's only patients who start to produce an antibody and develop these memory B cells, which can persistently lead to more antibodies in the future. If you will, the patient, sort of like getting a vaccine to make it produce an antibody, the body almost self-vaccinated to produce these antibodies is a simple way of looking at it. But that's after the fact. There are certainly a lot more people that have low levels of ADAMTS13 activity that we never hear about because they never get into trouble. How many is an excellent question.
Is splenectomy still used as a treatment for TTP?
Do you want to go ahead?
So splenectomy, it's one of probably the treatment that's considered for refractory or very relapsing and not responding to any treatment. It's not very commonly used, but still mentioned in a number of published reports. I don't know about your practices if you use any splenectomy in refractory cases.
Yeah. I think that when I think about splenectomy for TTP, I think of it as a tool to prevent relapses, not so much as a therapy that I would like to do in someone that is having an acute episode at the moment, because it would be a very high risk surgery. But certainly when done in a patient that has had multiple relapses, and he's received rituximab, maybe other immunosuppressant, and still having relapses, we've used splenectomy, and it's been very successful at prevent future episodes.
Yeah, I mean, a lot of things in the past were done for refractory disease. There's 10 to 15% of patients who don't go into remission. And splenectomy was one of them. But it's really, in some studies, it's now been shown doing this for refractory disease was incredibly dangerous, the complications. I mean, this disease was treated with splenectomy prior to having plasma exchange. But all that discussion, it really is put aside. With caplacizumab can really, for the most part, prevent these refractory patients. You kind of get into a different situation, meaning you can block the disease. Now you've got to get rid of this antibody still. But as Camilla said, it seems to be an effective tool for some patients with relapsing disease and preventing relapse. That study I mentioned from the Swiss group where they found these memory B cells. So in some patients, you could be removing memory B cells from a spleen that are leading to this relapsing disease. So it's, again, I think what you'll see in the future is more of a focus on why relapses occur as the acute treatment gets to be better. I think less morbid for patients. So a lot to learn.
What are the treatment options for a Jehovah's Witness with TTP?
It's a good question. So they were there. We say the canary in the coal mine. Out of necessity, a patient whose religious belief won't let them get a blood product is where the first patient down in the Louisiana area was treated with caplacizumab without plasma and was able to recover. And that led to additional patients being studied in some of the work that I talked about to use caplacizumab without plasma exchange. So really, yes, it can be effective. And out of necessity, it was shown to be effective in the first patient. And that led to non-Jehovah's Witnesses being tested. So you're going to see more studies in this approach of not using plasma exchange. But the short answer is yes. It's been done, it's been reported.
So caplacizumab is what you're saying the treatment for a Jehovah's Witness would be for the future?
Well, yes and no. So yes, that's what I would do today, but it's not, caplacizumab is not, to be accurate, it's not FDA approved to be used without plasma exchange. It would be considered an off-label use. But in the context of not having plasma exchange, were I in that situation, I think caplacizumab is what I would prefer. In addition to the treatments to suppress the antibody production, which, as you saw from my slides, takes some time. So you've got to do something in the interim.
And is caplacizumab available in all U.S. hospitals?
So oftentimes, more often than not, it will not be seated sort of in the pharmacy of every hospital in the U.S., but it is readily available. If a physician encounters a patient with TTP, to be ordered and shipped fast, yes.
Is there any reason a person with TTP couldn't be a blood donor? Is there any concern about them donating blood?
Certainly not while they're having an acute episode of TTP, but I
don't think any of the treatments are, from being a blood donor, I don't think any of the treatments are excluding you. They do ask about blood diseases. And
yeah, if you're on remission with a history of TTP, you're not gonna sort of pass these autoantibodies to the person that you're donating the blood to.
Yeah, could you be a donor? Yes. It should wait till after you're in remission.
Yeah.
Good question. Nothing dangerous about a patient in recovery's blood compared to somebody else's.
How often does necrosis occur in TTP patients treated with steroids, and how would it be best to avoid it?
Go ahead. avascular necrosis and steroids?
So it should require some sort of a chronic steroid use. If you're taking steroids just for the acute episode and a few weeks after, it's less likely to happen. But chronic steroid use will lead to osteoporosis and avascular necrosis. But the brief pulse of steroids and the taper after should not cause AVN unless you have pre-existing AVN from other causes and you exacerbate that with steroids.
Yeah, and I think that's a very good point, that we as hematologists need to do a better work, a better job at trying to reduce the time that we leave our patients on steroids, because not only necrosis, but a long-term use of steroids, even at lower dose, are associated with an infinite number of side effects, unfortunately. So patients may have a love-hate relationship with the medication, but we try to, we need to start it when you're having an acute episode, but we also need to do a fast taper so that you don't have all these side effects.
Yeah, I think that first month after they're out of the hospital, we try to get them off the steroids if we can. If they need long-term steroids, then they need an alternative treatment such as rituximab that has a longer effect and is safer. There's no absolute number of dose or doses that says you're going to get avascular necrosis, but I think it's safe to say the lower the dose, the better off you are, the less likely it to occur.
So this patient didn't respond to Rituxan when it was given to them when it looks like they were in an active episode. And there's a medication called Velcade that was used to get them into a remission state. What are some risk factors for patients that wouldn't respond to Rituxan? If you don't respond once, are you never going to respond? Should they not try it again? And how would you treat those patients? This patient was also pregnant, so do they have a higher risk of not responding during pregnancy, and is there a higher risk of TTP during pregnancy? I know we touched on that before, but just to cover it again.
I would walk it back for a second and say, what does work or not work mean? So if you give it up front for refractory disease, that slide I showed, it takes you a couple of weeks for it to help. So it's not the greatest treatment for refractory disease. The benefit is down the road. If we talk about the cleaner picture, which is looking at rituximab when it's given in remission, it is very effective, but all patients don't respond. And it's not clear if there's racial differences in the response or other factors that might occur. But can you respond once and not respond in the future and vice versa? I just had a patient recently who did not respond the first time around, and 2 years later, she did respond. So, do you have any thoughts?
Yeah, it's hard to predict if you respond one and you don't respond in the future. And just like you mentioned, it's going to take a short while to respond to the rituximab, and you continue the plasma exchange. Because you could belong to a category, you're slow responder, but you continue the same treatment, eventually can respond.
And to the point of your question, I guess if it was used in the setting of pregnancy, right? Mm-hmm. So certainly rituximab per se is not, I guess, FDA approved for its use during pregnancy, even though we use it when we need to. And more we're getting more experience in the use, and we're cautiously optimistic that it doesn't cause any side effects to either the mom and the baby, but that's, again, is officially not FDA approved. And, it's typically used to maintain an ADAMTS13 activity above 20% to prevent relapses. And I don't know in what context was it used in this case, but like Dr. Cataland said, for refractory TTP, rituximab is not really great because we're going to see an effect in a few days to 2 weeks to see an improvement.
Yeah, there was one comment about pregnancy and TTP. That is a very, very complicated issue that needs a multidisciplinary team. You need high-risk obstetrics involved. You need a hematologist involved that really has done this before. It's a complicated issue because ADAMTS deficiency in pregnancy is really a bad thing that can lead to bad outcomes in terms of relapse. So you kind of have to stay ahead of things. And again, it's more complicated than we can talk about in this forum, but really needs people who have done it before and been there before, an experienced center and physicians.
All right, another topic I know we've touched on in previous sessions. How long after completing rituximab would you recommend getting the COVID vaccine? Would you get it immediately after? Is there a waiting period? Is before the only way to do it?
I would say there's a number of variables that I would like to know to answer that question. Ideally, if one person can get the vaccine before receiving rituximab, thinking that you're getting rituximab sort of as a preemptive treatment to prevent future relapses, and it can wait a little bit, then I would try that. And if you recently received rituximab and it worked and your ADAMTS13 activity is normal, I would give it, because while it may not, as Dr. Mazepa said earlier, while it may not work it may not have the same effect as other patients not on immunosuppression, given the extent of COVID cases nationwide, I would like to offer as much protection as I can, but I don't think we have sort of a clear date to determine when to give it.
If we all pulled a number out, we'd get 3 different numbers. And if we asked
Yeah.
6 more people, we'd get 6 more different numbers.
Yeah, and it's also very related to how are we doing as a society. Maybe you live in a community, in a county that is having very few COVID cases and you can wait, then wait 3 to 6 months so you have the full benefit of the vaccine. But if you live in Florida, like I do, maybe I would be more aggressive and just give you the vaccine as soon as possible.
With an idea to revaccinate sooner. Again, that's off-label for a vaccine, but
Right.
what do you think?
Yeah, so I think it's a pandemic. If you can get the vaccine as soon as possible, that would be great. If you're on active treatment with steroids or Rituxan, begs the question, are you going to respond 100%? Maybe way less than that. So just a general recommendation, 3 to 6 months after end of immunosuppression, or what we believe you have immune reconstitution and you can respond to vaccination. But again, we are in the middle of a pandemic, so if you can get the vaccine and get some benefit, probably.
You're not going to hurt anybody.
No.
You may not benefit, but again, your concern guides how soon to get it.
This is kind of an interesting question. Is the ADAMTS13 always needed to cut the von Willebrand factor, or is it only ultra-large von Willebrand factor that it cuts? Also, this person read that high salt and dehydration can produce ultra-large von Willebrand factor strands. Should we try to prevent ultra-large von Willebrand from forming?
Well, it cleaves the big ultra-large pieces down to the normal size pieces. I don't, and that's thought to be the only function of this ADAMTS13 protease. There are some other, and Siddhi may have some comment. There are some other, I don't think, methods of or mechanism of cleavage in the body. Certainly nothing significant enough to overcome the lack of this, of the ADAMTS13 protease function. It's also unique that it's thought that this is the only function of this ADAMTS13. It's a good question.
High salt and dehydration, does that cause ultra-large von Willebrand factor?
I mean, it's an acute phase reactant. You see this why sometimes someone with congenital TTP might relapse during a pregnancy. The VWF levels go up and may be more problematic in the context of not being able to cut them. But it is an acute phase reactant, and there's a lot of things that can change. Dehydration and stress can lead to stress inflammation, which can be that second hit. So I can't tell you no, but I certainly can't tell you exactly what it's going to do. So can that play a role in the development of the disease in the context of low levels of activity? Yes, but there's nothing exact about that.
All right, and we've reached the time for this session. Thank you to our panelists. I appreciate everybody. And if your question wasn't answered or you haven't gotten a response, we will go into